Today, my patient was 52 years old and presented to the ED with increased difficulty swallowing and stated that he has not eaten or drank anything for the past 3 days. He is dehydrated and he says he always has a constant headache. He has a 20 gauge in his left AC at 125 mils per hour. He has a history of hypertension, acute renal failure, GERD, and COPD. He smokes 2 packs of cigarettes a day for the past 25 years, which is a contributing factor to his new diagnosis of dysphagia and achalasia. The patient was not a fall risk and was up ad lib. He had a potential risk for skin breakdown from the lack of adequate nutrition and hydration. The patient's respirations were 16 per minute, even in unlabored. Since he has a history of COPD and difficulty swallowing, it is important for me to monitor changes in respirations and lung sounds. He had diminished lung sounds in upper, lower, and middle lobes bilaterally and had inspiratory and expiratory wheezing. He presented with a productive cough that he states, "It's just my spit because I can't swallow anything." There were no abnormalities or signs of infection in the head, eyes, ears, or neck, but his mucous membranes were dry as expected due to his inability to swallow, leading to dehydration. The patient had dilated pupils out of 5 but reacted brisk. The patient also stated he has a constant headache that is always a 3 out of 10 but sometimes spikes a little higher, but he does not take any over-the-counter medications to alleviate the pain. No abnormalities related to his skin and is warm and dry to the touch. He is currently experiencing nausea and vomiting occasionally and was given Zofran, which alleviated the nausea and vomiting he is experiencing. He has 3 children that are now grown and out of the house and 6 grandchildren. The patient was on edge and antsy because he wanted to leave the hospital and to tend to his responsibilities outside the hospital. His coping strategies were appropriate for the situation, and his son and wife came to support him before and after his endoscopy. The endoscopy was being used as an exploratory procedure because the doctors were determining if the cause of dysphagia is related to cancerous growths in his esophagus. The patient is NPO both due to dysphagia and inability to swallow and for his procedure that took place at 2 p.m. The patient had albuterol treatments ordered PRN for dyspnea and had 1 treatment at 6:45 in the morning. It is important to teach the patient that they may experience tremors, insomnia, hypokalemia, and tachycardia after these treatments. Also, the patient should avoid smoking and caffeine while taking albuterol treatment. Before and after the treatment, the respiratory therapist assessed lung sounds and vital sounds to see the difference or see the effectiveness of the treatment. Zofran was also ordered PRN for the nausea. The side effects include headaches, constipation, wound healing problems, and hypoxia. With a history of COPD, it was important for me to monitor respirations and oxygen saturation very carefully. A potential cause of his constant headaches may have been exacerbated from the administration of Zofran. However, I think that his chronic headaches may be caused from working as a mechanic and smoking cigarettes daily for many years. The doctor ordered a CBC and a urinalysis. The CBC came back with elevated levels of chloride, glucose, and C-reactive protein. These results may be a result from stress of infection and being hospitalized, and the elevated CRP is a general indicator of inflammation in the body. The urinalysis showed no abnormalities. He had a chest x-ray done to identify the cause of wheezing, and the results showed a stable appearance of the chest with scarring and pleural thickening on the left. However, there are no acute pulmonary findings. He also had the CT of his neck and nasopharynx with IV contrast to identify the reason for pain and difficulty of swallowing. The results showed a subcutaneous nodule in the suboccipital region on the left of the midline, which is most likely a sebaceous cyst. There was also an air-filled mild dilation of the upper esophagus, which could potentially be a result of the achalasia. Some other healthcare disciplines involved in this patient's case was respiratory therapy, social work, and radiology. The respiratory therapist administered the albuterol treatments to help with his dyspnea. The social worker was involved because he was very concerned that he was not his wife's power of attorney, and it was hindering him from focusing on his own care. The social worker discussed options with him, and he said he felt more comfortable with the situation. And lastly, the radiologist performed the CT and X-ray images. Some referrals that may be beneficial in this patient's care may be dietary, speech therapy, or occupational therapy. Dietary may be beneficial for the patient to create a meal plan that has adequate nutrition but is also easy for the patient to swallow with his dysphagia. Speech therapy may be able to work with him on adaptable ways for him to cope with the difficulty of swallowing, and occupational therapy may be able to help him find ways to perform everyday tasks to help conserve energy due to working full-time and being the primary caregiver to his wife. The first patient problem that I identified today was impaired swallowing related to achalasia, as evidenced by not being able to eat or drink anything for the past 3 days, and not being able to swallow his own saliva. The first intervention was to rehydrate the patient according to orders. The patient had adequate amount of output at 132 mils at 8:30 in the morning of light yellow urine, which indicated hydration resuscitation. The second intervention is to monitor lung sounds every 4 hours to ensure no new onset of crackles or wheezing. The patient had no new onset of crackling or wheezing on the day of care. The third intervention is to maintain oral hygiene because it reduces the incidence of aspiration pneumonia. The patient brushed his teeth once during the day of care and used mouth swabs frequently throughout the day of care. And he also stated, "This feels so good, and I feel like I can focus more on what you guys are telling me now." The second patient problem is risk for deficient fluid volume related to inability to swallow liquids or solids. The first nursing intervention is to determine how long the patient has been NPO. The patient stated he has not had anything to drink in 3 days and has not eaten anything in 5 days. The second nursing intervention is to initiate fluid resuscitation. The patient has a 20 gauge in his left AC with 125 mils of normal saline running continuously. The third nursing intervention is monitoring input and output. The patient had an output of 132 mils at 8:30 and another urine output at 12, but not exact measurements were given due to the patient forgetting to use the urinal, and he had an intake of 875 mils on the day of care. The third patient problem is stress overload, related to his new diagnosis and being the primary caregiver of his wife. As evidenced by being so stressed about it, he requested to speak with the case manager about becoming his wife's POA. The first nursing intervention is to assess his stressors. The patient described the toll of the hospital stay had on his life and that he needs to be able to go home and care for his wife because everyone is going back to work and will not be able to take care of her if he stays in the hospital. The second nursing intervention is to refer the patient to other healthcare specialists to provide care related to the specific stressors. The patient was referred to the social worker and stated some of his questions were answered and they're helping him figure everything out. The third nursing intervention is to assess the patient's readiness to learn about potential coping strategies. The patient stated he only cared about how he was going to get out of the hospital to care for his wife, so I decided he was not ready to learn right then. Later on in the morning, the social worker came in to talk with him more, and he was ready at that point to learn. I felt like the care of this patient went very well today. He was agitated that he had to be there, but was very understanding and kind to me when I had to perform my head-to-toe assessment and get all the vital signs. I feel like my patient communication improved today because I found it very interesting to listen to the patient speak with other staff members because he was harsh with them. I feel confident in my patient care skills and working with the other people caring for my patient as well to provide the best care possible. Today as a nurse, I learned that sometimes my patient-nurse relationship will not be as elaborate as others, but that does not hinder the care they are receiving. I think the patient is receiving adequate and appropriate care for his condition and health.